Oh, yeah, it's light. You're up. Yeah, you're probably gonna have to get it at an angle, just because of how much. No.
And I have not asked them to prepare anything. Does anyone have any questions to get us started? Anything pressing? Okay. Go ahead.
I'm gonna ask you a question. A lot of times when I ask it, the answer is always, it all depends upon the individual. I would like to know what is normal range reading for a person who is on medication for diabetes. What number is it really like?
Yeah, sure. Now, I would say that a good range would be between 80 and 120 if you're diabetic. Yeah, that's a good range right there.
Okay, thank you very much. I don't know how long I've been trying to get
Okay.
Thank you.
Anybody else have any questions? I always have questions, so don't worry.
Okay, no problem.
Does anyone
You got
else have any? Alright. So I'm actually not gonna ask a specific question, but maybe each of you can just give us, either a situation that you've come across that's common, as far as a disparity maybe that you see in healthcare. Maybe there's a particular experience you have had that kind of sticks out for you. Maybe something, right now we're dealing a lot with mistrust of healthcare, especially related to vaccines and things of that nature. Some of that extends into communities of color for various historic reasons. So if any of you have maybe a common theme that you have seen that's related to disparity, or if you have something, a particular experience that kind of sticks out in your mind that you can share with us. No pressure.
Well, for me, the mistrust is a big one that I see a lot of time in primary care, where patients want to see providers that look a lot like them because they're more comfortable talking with them. And in this era where there's so much mistrust, a lot of it, of course, is around the vaccine, which this happened even before the vaccine, but it's even more now. I increasingly see people wanting to get the information from the right source. They hear so many things that they really don't understand, they really don't know. And I see that, and I always see how comfortable they feel when they come in. And when I have students that are trying to go to medical school, or going into any of the health field, most likely medical school, I always try to encourage them to try to associate yourself somewhat with areas where you can affect your own people, because they want the interaction with providers that look like them. In my practice, it's pretty diverse. I may have maybe about, well, I have a fair amount of African Americans, but I also have other races as well. So one of the things I try to do with that is I try to keep my staff diverse enough to reflect that. But I try to meet the needs of all of the people if I can. But I do have a soft spot in my heart for African Americans, because I realize, how much they really want to get information from someone that looks like them. And so many times, and I see it a lot with the vaccine. When I talk to the patients, they go, "Oh, nobody ever told me that. It was a good thing I came and talked to you." Because they see somebody that they trust. And so it's true pretty much with almost all my patients anyway. They always feel like they can come and talk to me. But I do find a soft spot for African Americans, because I know the history of what they've gone through in this country. Even though I didn't grow up in this country, I know about their history. And I know how much of mistrust they have with the healthcare system.
Well, I have it's not about the mistrust, but a disparity. So in the field of OBGYN, we deal a lot with counseling moms, prenatal care, and the main thing that we talk about, one of the themes that we talk about is breastfeeding. And I actually did a project on this, about the disparities that are in breastfeeding. And that a lot of times, you look at the rates of breastfeeding for women of color, Black women specifically, our rates of breastfeeding are far behind white women, Hispanic women, and other races of women. And so what I see in my own practice is we have kind of going along with seeing somebody who looks like you. At MUSC in Florence, we actually have a lactation consultant who's a Black woman, And she actually has been able to increase our breastfeeding rates because patients report that they actually more so feel comfortable talking to her, more comfortable getting information from her, that the breastfeeding rates that we had before actually have gone up. Whereas when I came from MUSC in Charleston, the rates there were still very low for African Americans. We also didn't have any African American lactation consultants in Charleston at the time that I was there. So it's still definitely a big issue for historical reasons that you guys can look into. It's very interesting in terms of the history of slavery and wet nursing, and I went very deep into it with my project. I learned a lot. But still to this day, there's still obviously a disparity among breastfeeding. A lot of Black women don't want to breastfeed for a variety of reasons, historical reasons that may come up, or family dynamics that may come up. But that's definitely a disparity that I see in my own practice, that a lot of patients of mine who are African American just don't want to talk about it, they don't want to breastfeed, they're ready to make their decision up, and they feel like formula and breastfeeding are pretty much similar, and that's of course not the case. That's one thing that I see in my practice that I have to kind of overcome. Sitting down, taking the time with women and talking about breastfeeding and how it is different and how it is optimal to formula feeding is a challenge that I face in my practice.
Do you know in the, I'm sorry, this is fascinating. Do you know in the literature, do you know what the actual difference between Blacks versus Caucasian as far as breastfeeding goes? Like what percentage
The numbers?
Yeah, numbers.
Yeah, I know them roughly. So a lot of those numbers come from the CDC breastfeeding rates. We look at them yearly, and the rates for initiation or starting any breastfeeding in the hospital for a white woman is probably closer to, let's say, 85% of just starting breastfeeding. Maybe not continuing, but starting. For Black women, it's probably closer to 65%. And then, but the disparities get even worse if you talk about breastfeeding durations, like for 2 months, 3 months, 6 months, 9 months. Probably about the 12-month mark in the United States, the Black woman's breastfeeding rate may be 10%, compared to a white woman might be 30 or 40. So all races need, it's low overall, but definitely there's a big disparity between Black and
So then the socioeconomic
sometimes, but not always. So a lot of times the breastfeeding rates are still lower among Black women of higher socioeconomic status compared to other races of women. So that's a good point. So when I was doing my research, just briefly, when they looked at Hispanic women and Black women, Hispanic women tend to have similar socioeconomic status as Black women do in a lot of cases, but the breastfeeding rates there's still a disparity there. And Hispanic women were breastfeeding at rates closer to Caucasian women, women of higher socioeconomic status compared to Black women, regardless of.
I'm sorry. I'm not asking about it. I'm actually going to ask about the social support. Because family and social support, there's something as intimate as breastfeeding and raising your child.
Right.
A lot of that has to do with your family structure. And so I'm fascinated by that. I'm looking into the literature. Would you see it? Maybe these Hispanic families or women who have a similar socioeconomic status as the Black women, maybe they have more family support that they can take care of, somebody who's taking care of them while they take care of the baby. That's why they have to breastfeed longer.
Exactly.
That's the reason, rather than there's something in the mindset of African American women that they don't want to breastfeed. Right. I come from Nigeria. Breastfeeding wasn't a big deal. It was that we formula fed.
Right.
That was everybody formula fed.
I didn't realize that. Yeah.
Yeah. In the 80s and everybody formula fed. It was only like recently that we were told, hey, breastfeed it, you should be breastfeeding and all that stuff. But yeah, fascinating. Carry on.
Yeah, go ahead.
So I heard a lot of stuff about how Black females have a lot more complications during, not surgery, pregnancy and when they labor. Thank you. That's the word I'm looking for. I just couldn't spit it out. But I've heard a lot of things about how we have more complications. Complications, thank you, more so than Caucasian women. So can y'all explain on why that is, maybe?
So it's going to be multifactorial, of course, but just what I see in my practice, sometimes we do have African Americans who carry more weight, so that we know that can be true at times. And so in pregnancy, and with most medical problems, when you carry more weight, you have higher risk for things like high blood pressure, diabetes, preeclampsia, all things that are going to make pregnancy more difficult. So I think that plays a role into it. Diet, I'm sure, plays a role into it too. And there is some concern and some thought about bias as well when it comes to a Black woman coming in with a complaint, white woman coming in with a complaint. Are they both taken seriously? Are they both looked at, with the same concern? There's some thought that that may not be true. There may be some bias there where things are misdiagnosed or diagnosed late, and people have complications from that. So that's a concern too. It's kind of it's hard to prove that, but there is some thought about that in cases that we've seen or we're looking into of concern about bias. That's a little bit about it.
Is access to care also an issue for certain parts of the country or certain parts of the area?
Yeah, so there are access to care issues even around here in many of the smaller towns. I'm from Marion. The labor delivery unit is closed there, just like in many small towns in the state, and I'm sure out of the state too. A lot of labor delivery units are closing down. Women are having to travel, hour, 2 hours for the doctor's visit, so that may be difficult to do. And then of course having to travel for labor and delivery, having complications at your local area, having to go to the emergency room where there's no OBGYN even on the premises. So access to care is a big issue. I think across the country, it's just OBGYN units are closing down, and a lot of that care is being centralized into a few spots in the state that make women have a more difficult time to get care. It's a big issue. That's a good point.
I have a question. Why is it that they're closing down?
So I can't tell you that I know for sure. I'm assuming it's financial. Most things are financial. It may not be cost effective. I know in Marion, they would only do, a few deliveries a month. So it's not cost effective to have a whole unit that has to be staffed 24 hours a day, anesthesia, pediatrics, nursing. It wasn't really making money, at least the Marion situation, because I'd be able to keep it open in that area. They weren't seeing enough patients. I'm sure it's more than that. So that's what I know.
Okay.
Did you have to do clinical research and independent, or just one?
You mean for training?
Yeah.
So for training, I did bachelor's degree and then medical school, which is 4 years, and then I did residency, which is 4 years. In most residency programs, we have to do a research project. You pick a project and you have a mentor to help you get through that. And you may or may not publish it. You have to do some kind of some kind of typically clinical research in residency training. You want to do that?
It's not quite research.
Do you find that a lot of minorities do not seek mental health care? I ask because I usually have a lot of students that they do come and they talk to me, and usually they would end up dropping out of the semester because of mental health problems. And they're very reluctant to talk about it, their mental health problems, and then I would ask them why, just to get them to talk, and a lot of them say, because I don't want you to think bad of me or look down on me. And so do you see that a lot in healthcare for minorities?
Yeah, well, I see it a few times. And usually by the time they come and see me, they're pretty bad off. They've tried everything, exercise, they've gone to church, they've tried to talk to family members, and, despite that, they still have significant problems. I find it even more difficult for males, as opposed to females. Females are more likely to come to a physician after they've tried everything and nothing works, to get some help. Now, many men, they may resort to things such as alcohol or drugs before it gets to the point where they can come and see a physician. But yeah, and I guess there's that stigma of being a Black male or female that you're weak if you try to get help for mental problems, because, you know, they think, well, you know, my ancestors went through slavery and they were able to make it, and went through Jim Crow and, you know, everything else. And now, you know, as bad as I have it, it was never, as my ancestors had, a lot worse. So, you know, it's very difficult for them to come and see us about something like that.
This might not relate to what we're talking about, but, can you refer to ways to cope with mental health issues while in college?
Well, you know, one of the first things I recommend is trying to find somebody to talk to, you know, just talking about what you're feeling. Exercise is always good. Healthy diet. Diet is so important. A lot of people don't realize how important diet is as far as helping not only your physical health, but your mental health too. And, you know, when all those fail, you know, come to a provider and just talk about it. See what kind of options.
I have students who have some students in the nursing program, not so much at FMU, but back when I was in Drexel. I had students who had either learning disabilities or mental health issues or anxiety. They were dealing with it. One of the things this is something that a student told me, which I pass on to other students, is to treat it like you would treat having bad eyesight.
Hypertension.
If you had bad eyesight, you would go to the optometrist to get it treated, to get an expert opinion, and then you get a plan of care. What do? Get your prescription. It's A, B, C, D, E. If you treat your mental health, same with it, you don't treat any physical ailments, then you will be better off. So whenever a student was failing or not doing well in clinical or academically at Drexel, I always said to them, one of the last questions I always ask is, how are you doing, like, mentally? And then that's when it'll come out, like, oh, I have really bad test anxiety. My palms get all sweaty. My heart's beating out of my chest whenever I have to test. And I know the material, I go in there, I take the test, I come out, and I have no idea what to do. So I'm like, that's clinical levels of anxiety right there. So have you seen somebody about this? And it's always those, you know. I'm like, well, we have counseling centers, we have, you know, have we tried, you know, reaching out to these resources? And that's always that's the way that I approach.
Yeah. You know, I tell you, I've been doing this long enough now to see every semester, give them about a good 3, 4 months, maybe the first semester, the second semester. Then I start to see a lot of the students coming in with this. And the majority of the time, they fail to take advantage of the resources that the universities have to offer, which is mental health facilities. They have it here, on the campus. And the majority of the time, they're paying for it. It's already in tuition, it's already calculated. And the other thing I see is that most students, most students don't see their issue as a mental health issue. And the same issue in the African American community. We don't own up to the fact that this is what's going on. And when I get a student that is so distraught over it, a lot of times I say what you just said, tell them to treat it like diabetes, hypertension, other problems. But I also say, you're not the only one. There are others. You are not the only race, because I can tell you, I was shocked, literally shocked, when I found out in medical school what some of my colleagues were dealing with and how they were managing it. I was literally just shocked when I found out, you know, and when I see others come through and people are failing and dropping out because of the mental health issues and they don't even know what this is, that's bothering them, they don't understand it, you know, it's something that's just not talked about in the African American community. Like I said, we don't own it as an issue. Others will own it, others will do okay with it, and they'll manage, and they'll come out on top, they'll run businesses, they'll be bankers, they'll be political affiliates in the community. They just do well, you know, they do perfect, and you wonder, really? You have a diagnosis? Really? Oh my God, I know somebody else who was like that. And I know they were smart, but they never did well. They never owned up to the problem. And they never owned up that this could be an issue. So I always say, when I have my students say, listen, let's start first of all, you're not by yourself. This is not a new problem. I see it all the time. The one that's always saddest for me, which I don't think they can really predict this per se, but the one I see, I've seen about 2 years or so though, is maybe about beginning of sophomore year. I'll see a student having a schizophrenic break from the stress of college. You know, it's just really, you know, and so that one I don't, they may not necessarily know, because a lot of sometimes it depends on their lifestyle, or if you really talk about they have a family history, but they didn't realize what was going on, and they have a really schizophrenic break. But the other things like the anxiety, the ADHD, the dyslexia, the depression, all those things, you just have to own that that's what it is. And then we go into dealing with it. It doesn't have to be necessarily prescriptions that deal with it. You know, there are coping skills that the person may need. You know, there are persons in the community that they can talk to and be able to deal with it and work through it and realize that it really is okay and you can function very well and you can complete college.
That's one thing you said, that students don't make use of their resources. Do we know, Rhonda, do you know like how many like nursing students, minority nursing students actually use the counseling center or use the testing center as opposed to like the Caucasian students?
I can probably count about 5 minority students.
Yeah, out of.
There are more Caucasian students than
Much more.
Counseling testing.
Shame, because they all pay the same tuition.
But yeah, but a lot of the two, they don't know. That's the thing. A lot of them don't realize that it's okay. It really is. You know, and you know, the person, if you look at the person on the left, they're probably having the person on the right. They probably have, don't look behind you, they're probably 10 more behind you. You know, so, you know, you just own up to the fact that this is a problem, it is a concern, it's an illness, I mean, just have to deal with it, or maybe just a minor disability, but you can function with it. You can do just fine. I see it all the time.
I have go ahead.
I was just going to ask, would any of you be willing to share any experiences or challenges that you had going through medical school, being a person of color, and maybe challenges because of that? Did you perceive to be treated differently, or were higher expectations placed upon you when you were going through your studies? And what advice would you have for students who are currently going into the healthcare field?
I'll start. So, or is that taboo subject?
No, it's not. It's not.
So, so in residency, I was in OBGYN residency, already tough because it's surgical, we do surgery, it's a surgical specialty. But I do feel like, so in my class, I was only Black resident out of 6. In the whole program of 24 residents, there may have been 3 of us, maybe 3 Black residents, all female. So I do feel like in residency, especially intern year, I do feel like treatment was a little bit different. It was subtle. I would say that a lot of times for the same, mistakes that were had by me, for example, my colleagues, same mistake that was had by them, I definitely felt like I was more heavily reprimanded. I noticed it, probably even more so the students that worked under us, they would notice it and tell me that, they would kind of come back to me and say, I feel like, they treated you this way and that way. Even when I didn't notice it, they would come to me and tell me they felt like I was really being very harshly treated. So I do feel like there was a difference there, at least in my case. I would say that sometimes, if a question wasn't answered properly, it was thought maybe that I'm not smart. Whereas if a question wasn't answered right by someone else, thought that, oh, she's just, she forgot, or she's having a rough day, or, whatever. So I do think that some of that, it was there and existed in my situation, definitely. So, but with that being said, I do feel like I did have mentors. I did have people that I could go to help talk through some of these things that were in my program, but also those that were not in my program in terms of faculty. So it's helpful to have some support because you are going to face different things and some different challenges in your programs. But what I would say too, to tag along with that, is in medical school and residency, in training of any kind really, a lot of times I felt like the Black students were treated, we may not have spoken up a lot to answer questions or to give our input a lot, and because we didn't, or because maybe we were afraid to speak up, we were looked at as if we just didn't know, we weren't smart, or maybe we just were thinking or, trying to give somebody else a chance to answer. So a lot of times it's cultural, and I would tell anyone who's going into medical school or medical training to, as much as you can, try to speak up, try to express and say what you know, because it will be looked negatively upon if you don't speak up. You'll be thought of as if you just don't know, but really you likely do know, you just not comfortable speaking up. So.
For me, I think I went in already feeling like there's some inferiority complex a little bit. Because, in my class was the largest class of minorities they ever had at MUSC, 7. And we had 137 students, so one had 7. So there was a little bit for me going in feeling like, oh my God, geez. But the one thing that kept ringing in my head was an attorney said to me, he said, okay, you're gonna go to medical school now. Everybody's gonna start at 0. He said, you have to, technically, for starting, he was like, you're just as smart as everybody else. You've got to go in there remembering that. Just think of that everybody's starting at 0 level, okay? So I sort of kept that in mind some, and that sort of helped me through a little bit. Having mentors to talk to was also an excellent thing, because we had the Office of Minority Affairs at USC that also helped quite a bit. But I think the one thing that did it for me, I never forget, it was anatomy class. This was my first semester. I don't know if you remember, but you may have heard of the show Grey's Anatomy. But the book, one of the authors of Grey's Anatomy decided she was going to retire in South Carolina, and she was going to teach at USC. I don't know if she was living here, Sharon Callicino. Sharon Callicino. I would never forget her. If you look at Grey's Anatomy, she's listed as one of the authors, and she retired. She was teaching anatomy class, and she was from the north. Very different. You can tell by her accent. Much clothes she wore. It was cold and stuff. She had on shorts and tank top and all of that. And we were in anatomy class doing an oral exam. It was 4 to a cadaver, so I was right on my cadaver. I mean, I knew all the parts, I knew everything, And she came up and asked, and everybody was answering and all this stuff. And then she said, "You." Oh, shucks. And she was nothing but a nerve. I'm having a nerve now. I mean, I knew exactly where it was. And I was like, she said, I'm tired of it. I'm tired of it. Every time I ask you something, you clamor. I'm tired of it. This is the last time you're going to clamor, because I know you know it. I know you know it. Don't do it anymore. When I ask you, you tell me what it is. Now, where's so-and-so nerve? And I went, oh, it's right there. And after class, she cornered me again. She said, why do you do that? She said, I don't need you to do that. Don't get nervous. Just answer the question. I said, I know you're smart. I know you know. You wouldn't have been here if you're not smart. So just come on and say to me. And that really helped me a lot. It boosted my confidence a lot, And so it helped me to get through. And when I got to where I could see some of the disparities and how I never noticed it with me, but I noticed it with other minorities, how they were treated badly, unnecessarily, as opposed to others. It really helped me, and it gave me an opportunity to speak up. Because it also gave me a chance to serve on the admissions committee, because it was after that first year that somebody asked me about it. I said, you know what, I think I'm going to do it, and I'm going to start speaking up. And so it really helped me a lot. And so, what she's saying is right. Speak up when you get a chance to get on committees, get involved and start talking, build your confidence up starting now. Because when you get to where it's really challenging and tough, you don't need to have an inferior complex, because it will take you down, all the way down.
Just to parent off of that, speaking up, for those of us who are introverts and who don't like putting ourselves out there, that's especially challenging. It's something I have to train myself to actually do. I all the time when, let me give you a recent example, most recent example. I take students to, we do health screening at King Street. And we do blood pressures, we do after checks, blood sugar testing, cholesterol testing, and we talk to the residents that have residents, but like patrons that. And I had one student one week, and one of the patrons comes in and he looks right at me and he says, "Yeah, where's your instructor?" Like, where's the nurse? And I was like, And so like, so what that taught me, like from then on, I was like, you know what? From here on, it's not gonna happen again. What I do now, every time in a professional setting where I need people to know that I'm the one here in charge, I make sure that I'm dressed. I have my ID badge on, right there, and I have my stethoscope on, and I have my white coat over it, just so that there is no mistaking. And if anybody who's coming in there to do that I've met before, and I see it, I put myself out there and say, hi, I'm Dr. Chico O'Malley. These are my students. So I find that if I do that first, and we establish where everybody is and all that stuff, and then they don't feel comfortable, they're uncomfortable for, offending me in some way, So Dr. Jackson's really right, put yourself up.
I think I saw it more in the hospital when I came to
Yeah.
residency than anything else.
Oh,
That's where I saw it.
Patients and stuff.
Oh my God, I'm like, so you're gonna, you need I don't know, maybe, let's say a bed pamper. Okay,
Yeah.
fine. So you're gonna not ask the nurse who knows where it is, and say, don't ask me, I have no idea. I don't even know how to press the button on the bed.
My aunt had the geriatrician. I was talking to her about this, and she said that how many, especially she's a geriatrician, geriatrics is the older population. She said she sees it so much more in the older population. The patients, she walks to the patient room to go see patients, and they'll say, "Oh, yeah, I've been waiting for you. I need to go to the bathroom." And she's like, when that happens, it puts her in such a box because it's like if she refuses, right, then she's not being therapeutic, she's not being compassionate, and they'll just write her up for being a horrible physician and being mean to them, right? And then if she agrees, then she's wasted her time that she should be, consulting with the patient. So it's like she says it's really, really figure out. And so you don't really necessarily blame the patients because the only interaction they have with somebody of color is their mental health aid.
Yeah.
Right.
So that's what they know, and I don't have the answer, but.
So do all of you kind of consistently find that any sort of unfair treatment you get, potentially because of your race or maybe your gender, is more so from patients than from colleagues, or is it no, Dr. Rice and
I find it's
Across the board.
Yeah,
It's across the board.
it's a mindset that is pervasive in the population. So it shows up in the patient population. And I think it's more hurtful when you see it within your colleagues and your contemporaries. Because with patients, you'd say patients are they're not well, they're vulnerable. And so I tend to mentally I forgive them for whatever, because you're not well, you're not right. So but sorry, am I being beautiful? But with your contemporaries, your colleagues who you expect to have your back, this whole thing of having different standards for the Caucasian students versus the Black students, it shows up across the board. When I was at work at Drexel, I would never dare to go into work with sneakers looking casual because so it's like a different set of standards that you deal with. So it's across the board. It's not just for me. I find it's across the board.
It's across the board.
Yeah. And then also, sorry, I'm monopolizing everybody. It's not just being Black, it's also this whole idea of having an accent. If you're not from here, if you were not raised, if you're not born and raised here, there's also that barrier that you have to jump over. So I've heard my fellow Nigerians say to me that I'm so lucky that I don't have a Nigerian accent, that they have to deal with that. And I'm like, I'm sad. These are like super smart people, like way smarter than anybody, but they still have to, because they have an accent, they have to, there's an extra hurdle for them to get over.
Does anyone else have a question? I have a question, kind of circling back a little bit, so we're talking about healthcare, and do you all see, or maybe you've read or not, I'm not sure, but are there connections that you see between sort of stress and trauma and everyday just pressures of being a person of color in this society that somehow compile and affect the physical health of patients that you have?
Yeah, I see that, I do. You know, I've said this before and I've said it again. America is stressful. America is very, very stressful. When you travel overseas, I know it's happened to me several times. When I go away overseas, everybody is so lax. And if I go for a while, or the last time I went, I don't remember where I went, and I remember coming back. And when I stepped off the plane, I was like, oh, my suitcase, come on. I'm going. Giselle, calm down. I'm like, great. But then I hear CNN right there. Then I walk in there, MSNBC's over there, there's TV. Everybody's watching to see what's going on. Somebody's shooting somebody. The whole society is just can be so stressful that I think we see it in everyday situations, even with patients. It spills over into their lives and how they really respond, how they behave. You know, sleeping disorders, you see eating disorders. And a lot of it's just from the stress of everyday society. It's just so much in America. I had a friend who told me, she says, no, I'm not going back to America. She says, it's too stressful. I go, do you work? She said, yeah, I work. I make more money than I was in America. I said, well, what do you do? I don't know. When I get up, I go back to work. So I said, and when I see the, I call so-and-so and I try to figure out what's going on. And then I send some money, but I invested this and I invested that. I said, and she really does. She made a lot. Now she eventually moved back here because her daughter wanted to go to school in America. And she moved back here for high school. And she's already telling me, she said, I'm telling you, when she goes to college, we're heading right back overseas. It says it's too much in America. It's just too much. It's stressful. You know, you don't realize it. You got a big house because you make a certain salary. You got to get a big enough house. You have to write it off on taxes. You got to do this for that. It's so much that it really affects people's health. Their blood pressures stay up. You know, they don't eat well. During the last administration, we had so many people with heart attacks and chest pain and stroke to come in and said, I'm trying not to watch TV, but I just can't get away from it. It spills over in your life. This society is just so stressful that we do see it spilling over into the healthcare system.
Yes, like in relation to the stress, do you think the stress comes from all of this information overload?
Some of it is information overload,
Okay.
and it becomes very, very, very stressful. So it's that and just things that are you're expected to do.
Right. That's my,
You know, you have to be on time. You have to be here. You have to be there. You have to be this. It's just so much, and I don't think people really think about it. And when I get people that are really, really stressed, I'll say, stop it, step back, think about it. And when I bring it to attention, they go, you know, I never really thought about it. You're right. That's really what's really bothering me. So it's stressful, and we see it in every day in the healthcare. The patients that come in to see us. Money for medicine, money for this, and all this other stuff is very stressful. You know, so it's very stressful.
I have another question to piggyback off of, we as people of color not always speaking up and being a patient advocate. A lot of times last year, I had to accompany my mom to several doctor's visits, and so often when she was in the exam room with the doctor, she didn't know what questions to ask or if information was being shared with her. I had to literally ask her, did you understand what was said? No. Well, and ask the doctor, can you break down this information for her, so she can understand it? So can you share the importance of, I guess more or less being willing to speak up and ask those questions, and if you don't know what questions to ask, but just being the importance of being a patient advocate for family members when they make that doctor's visit? Or have you ever seen any disparities, especially with African-American patients and their interactions with doctors that may not be of the same background?
Well, I think it's very important that as a physician, you explain things in a way that a patient can understand, because if you don't, they don't understand it. They're not going to take the medications the way they're supposed to. I mean, they're like, well, I don't know why I'm supposed to take this, so I'm not going to take it. So, when I see my patients, I make sure that, I break things down and I ask them, are there any other questions? Is there anything that you want to ask me? But I think it's very important as a physician that you actually make sure your patient understands what's going on. And it's good that you're there with your mother because, I find that many older patients are unwilling to ask because they feel as if the doctor may look down on them, that they may be ignorant. So, as an advocate, it's very important to be there for your mom.
And a lot of seniors are not educated. Some of them, well, we still see some that are in their 70s and 80s, maybe on up. You may see some that are not. And coming to a physician can be intimidating for a lot of people because the first thing they think about is this level of education they have. But the one thing I tell people sometimes is, okay, so yeah, I may know medicine, but you're a plumber. I know nothing about plumbing. I know nothing about fixing a car. I'm not smart when it comes to that kind of stuff, So I know what I know and I'll do what I do, but don't be intimidated by me. Just talk to me, And so I try to encourage the seniors to do that, to talk. Sometimes you don't have enough time to talk, but we try to make sure that you can explain things to the patients and try to encourage them. When I do senior talks, I try to encourage the seniors to write down things and bring someone with them. Sometimes they don't want to because they don't want the children in their business and all this kind of stuff, But it is important that seniors know that they can ask questions and from time to time. When I leave here, I'm going to go to the hospital. I'm not supposed to be at the hospital, but I'm going to the hospital and I leave here because I have a staff member whose family's in the hospital. And they said, yeah, the doctor's been in, we don't understand a thing. We don't know what's going on. Every time the nurse comes and says something, we don't understand. So, going over there to say to the physician, what is it? What's wrong? Tell me. Let me tell them. Because sometimes it can be very intimidating. And I think seniors just need to be encouraged, and even minors too. Sometimes they think they know everything, but have someone to be able to advocate for them so that they get the right information. One of the things I know about me, and my staff already knows this, I talk fast sometimes. And so when they realize that somebody didn't understand, they come and say, they didn't understand any of your words you said, you talk a little too fast. I'll have to go back to slow down and translate. And I tell them that to make sure that my patients know. You don't catch them all, but we try to. But
Yeah, I would definitely recommend, especially for inpatient people that are in the hospital, if someone can be there with them, especially when they're there because they're ill in most cases. And so having a family member there that can ask questions is important because medical errors do happen. Mistakes happen, medical errors happen. And if you have someone there sick and you have somebody there with them that can ask questions and kind of double check on things, that's important. It's another level of safety, I think. So in cases where I have a mother-in-law in the hospital and other family members in the hospital, me being there having some knowledge, to be able to ask questions and answer their questions and tell them what's going on is helpful. But even if you're not in the medical field, if you got somebody with a sound mind and can be there with somebody who's ill, they can pick up on things and hopefully make sense of the situation. So the person who's there sick, can be the best taken care of. So it's important.
So I have another question. So something that I have seen, I know my family personally, and I think it's pretty pervasive in Black families, especially here in the South, is Dr. Jackson, you kind of pointed this out. We don't share with each other, right? So I had a medical experience, and the physician was asking me about my family history, my parents. I was like, I don't know, right? And that's dangerous because there could be something in the family that I need to know. So my question is that something that you commonly see? And if so, do you see it more in Black families than families that are not? And how do you address that? Like, how do you get, how do I get my mom to start telling me things? How do I get my granny to start telling me about medical history so that I can know for myself and tell my children or whoever else needs to know?
Now, well, with the Affordable Care Act now, all physicians have to have some kind of electronic medical record. That's why if they don't have it, most of them are not able to stay in practice unless they're going to do what they call concierge, which is really at different levels now, which is more pretty much you just pay me and come on in we're not doing any insurance, we're not doing anything. So you can always practice like that. But the majority of them, if you're gonna accept any kind of Medicare, Medicaid funding or any kind of insurance funding, you have to actually have electronic medical record. And so part of it is usually asking the family history and trying to dig deep into that family history. And when I have younger people that come in, I'll review their family history and I try to get them now. Every now and then I come across where I've seen generations. And I see the young person, I'll ask, do you have anybody with hypertension? No, and I'm going, you just saw your grandmama list. And I know what your grandmama has. That's what I'm thinking to myself, but I can't quite say that. You know. So what I say to that young child is, I want you to go and ask, and I've done it several times. I say, ask your family, are there any health issues? Because people are very hesitant, even my own family. Because a lot of my family members will talk to me confidential about things, and I'll say to them, your children need to know. And when I have reunions, sometimes I'll say, all right, part of the game is going to be what illness you have that you're going to share with everybody else. And sometimes it's really hard. It's really hard. Don't let it be a cancer. And nobody wants to talk about it, you know. And so it's very hard getting families to do that. And we see it, I see it more, I think, in African Americans. I do see it more in African Americans. Like I said, the electronic medical record does help some because everybody's being asked the same question, so it sort of gets it out. But I do see where they don't share information a lot at all. And trying to encourage you that that's important.
And Nigerians too.
Yeah.
In my Nigerian family, we have nobody says anything about any health issues. Heaven forbid you have mental health issues. Oh gosh, no. Nothing ever happens. You know? So yeah. So, and they deliberately keep this stuff quiet, like cancer diagnosis and stuff. One of my cousins was diagnosed with breast cancer in May. 3 days ago, I got a WhatsApp. You guys know about WhatsApp? Mm-hmm. I got added to a WhatsApp group. We're raising money to fund people. And I'm like, what? Huh? You know? And they're like, oh, by the way, Haman doesn't know. Don't tell Haman. Like, come on. Yeah, it's a cultural thing. It's very, yeah.
Why do you think that is? Why?
Historically, I just think we've just
maybe it's superstition and stuff. Maybe they don't want to tell the mom because they think the mom's gonna die of a heart attack immediately. Well, but it's just, I just have a problem with that. And when I tell them I have an issue with it, they just like wave their hands. Oh, you're Americanized. Yeah, they're like, this is a very American mindset you have.
And you know, a lot of my patients, they say, well, I won't claim that. So I guess they figure that claiming it's a reality. If they just ignore it, it's going to go away.
They ignore it, it's going to go away. They pray hard about it, and you know, that they will, you know, not that you shouldn't pray, but
you can't ignore it though.
Yeah,
ignore it, pray, you got to do it.
Yeah. But this whole thing that your family needs to know what's going on with you, it's so crucial and it's so important. And you need to know your ancestors too. Really, really important.
A lot of times if I see it, if it's something really significant, I'm like, this has got to be family history. And I'll say, you need to ask, you need to talk about it, you need to really find out. You know, find out what's going on. You know, it's almost as bad as having a set of Caucasian kids and they have sickle cell trait. You go, oh. Exactly. Yeah. What? You know, somebody's not saying something. You know, like, you need to go find out what's going on.
Exactly. That's really, really prevalent also in Nigeria. It's only like in the past, I would say 20, 25, 30 years that we started testing people who engaged couples who get tested for the sickle cell trait. So that was a huge deal.
Yeah.
I have several cousins who have sickle cell anemia. I know we need to know this. You know?
She had a question.
I just want to know how we get our family members to talk about their health issues, because I think it's hard for them to talk about it because they just don't want nobody to know. But it comes up later and you ask about it and they still don't want to tell.
Yeah. It's tough. It's, you know, you just have to talk about it. Like I said, what I did at my family reunion, I've done it's time to do it again, is we just have everybody just write down the health problem they think is significant. They all put it, you know, we don't have to see them do this, put it in the bucket. And then because most of them trust me, I just pick it up and just read. Well, We have hyperthyroidism, we have hypothyroidism, we have hypertension, we had schizophrenia. I'm gonna go, schizophrenia? Who's got schizophrenia? I'm right beside you, oh, we got that. And so we just started reading them out, and then don't mention them all. Leave it alone. And then after a while, I sort of come back around and I start doing talks on hypertension. So I do talks on those things that are really important. I mean, I just do it for my family, but you may want to just, that's one thing you can probably try to do, but try to get people to sort of talk about it and talk about it more and more. When they ask, well, what ideas, what can we do at this event? If you can say, this is what we can do. Let's talk about health issues. Let's talk about stuff. Let's talk about the hair, whatever. Hair is like that, whatever. Hair is like that. Sort of try bringing things out. That's some of the things you can try to do to talk. But it's tough in the Black family now. It's tough. Yeah, you just gotta be able to encourage them, just talk about it all the time. And I think the more you talk about it, the more you bring it up, the more likely they will talk about it. If no one says anything and it's taboo, then it's gonna be a problem.
Normalize talking about your health.
Yeah. It's almost like incest and molestation. Or, that's taboo, you can't really talk about, no one wants to talk about that. But I find that, it's tough and it's painful. Talk about it more. Because if you don't talk about it, your children won't talk about it. And it could very happen to your children. You gotta start talking about it.
Especially how to feel it.
I'm gonna come around and collect cards for everybody. Even if you don't write on it, you just give it to me and I'll take it. Quick little intermission here. Anybody has a question while I'm doing this? Those please feel free to ask. You can walk as quietly as possible. Morgan, if you have advice or a story or anything to share.
Can I ask this? Should a man get checked for breast cancer?
So I'll tell you, I don't know all the details, but I know that men can get breast cancer.
Right.
And if some men are at higher risk, like say you, for example, say you have a man in your family who had breast cancer, then that means the women and you also will be at higher risk for breast cancer. If you have male breast cancer in your family, you typically want to sit and talk with like a genetics counselor to see what your risk would be. And then from there, they can tell you how to get screened. I don't know what kind of, I'm assuming they may be like an MRI, some kind of imaging for the men. I don't know exactly what that is. But
I think when you come to the issue about, someone in your family had it, they're not gonna say it.
Yeah, they're not gonna say.
Especially, especially if it's male.
Yeah, they're not gonna say.
I was asking, just if there's any type of, because.
Risk testing.
So if you can have an early detection, about that.
No, there's no, because the percentage is so small that there's really no screening or studies that was done. Most time when men have breast cancer, they feel a lump. And more often than not, when they feel a lump, it's really metastatic if they're cancer early, but most times it's just feel a lump. That's it. And there's no screening.
At what age are you able to get tested for breast cancer? Or
like screening, like mammograms. So that the routine age, if you don't have any significant family history or any problems, is 40 for women, age 40. But if you have family history, then normally you want to start getting breast screenings 10 years before your close relative who had breast cancer. Your mom had it at 40. You may need to start getting screened at 30. And it may not be a mammogram, it may be a breast ultrasound. It would be a different form of imaging, but you would need imaging sooner if you have a family history. But normally it's just 40 with no problems, no family history. And talking to that, if you get that history from your family, talking about that with your primary care or your OBGYN, they can help guide you if you need earlier screening or extra screening based off your history. But we do start doing breast exams, like physical breast exams in the office, probably by 21 if you don't have any medical problems. Before that, if you feel anything.
So question about pap smears. We were having a debate, not a debate, but we forgot what the name was called. But what's a good age to get your first pap smear? Because I hear it's 21. So it's 21?
It's 21. The only time we do it before 21 is if we have someone who
who has a very low or decreased immune system. Some HIV patients, for example, will start having them kind of within a year or so of their diagnosis of HIV or any other kind of severe immune compromise, but otherwise, 21. Regardless of sexual activity, 21.
Is it something to be scared of? Like, I guess
No.
It's not, I hear so many different things about it.
It's not bad. It takes about 2 minutes, a little bit of pressure, it's fine. Don't worry. Okay, what I tell you. Here's what I tell you. Since everybody's an adult in here. Everybody's an adult. So when I get a woman who, especially, now she's never been sexually active, I don't do it, but if they're sexually active and they're scared, I say, okay, this is not spectrum, it's about as long as a penis. You okay? Oh, because it shocks them that I would say, so they're like still in shock, you know. By the time they get out of the shock, I'm already down there. But don't be nervous, don't be scared. It's uncomfortable, but it's not bad. But by the time you get to 25, as a woman, you've lost all pride and everything. So I can go away. Everybody, you always got something going on now. They gotta be looking. So don't worry, you'll be all right.
Thank you.
You're welcome.
Okay, I do have a couple questions on the part. Go ahead, sorry. Go ahead.
Oh, I just have one more question. No, today women are having children at older ages. So I was gonna know, are there like any common complications those women may have with giving birth at that older ages?
Yeah, so as we get older, typically, late 30s, early 40s, risk for things go up, risk for miscarriage goes up, preeclampsia, which is high blood pressure, pregnancy, diabetes, so medical problems go up, so therefore medical problems in pregnancy will go up. Interestingly enough, the risk of multiples, so like twins and triplets, risk of that goes up as well, the older you are when you conceive. Those are the ones that kind of come to mind. Obviously it can be harder to get pregnant the older you get because your ovaries just don't work quite as well. You may need assistance in getting pregnant, things like IVF or in vitro fertilization, fertility help as we get older. But the biggest thing also, genetic things. So as women get older, they have a higher risk for having a child with Down syndrome, other chromosomal problems. So we really do universal testing now for all women who want it, regardless of age. We do Down syndrome testing for those women, for everybody. But definitely if you're over 35, then we do it. We recommend it then, because your risk goes up for Down syndrome. Thank you. You're welcome.
I would like to interject, late 30s is not old, I'm just gonna.
I agree. I agree.
Okay. I have some hard questions. So first, how can a self-diagnosed miscarriage maybe affect the body?
Repeat the question, I'm sorry.
It says, how can a self-diagnosed miscarriage maybe affect the body? So maybe like spontaneous miscarriage, I guess.
How can it affect the body? Okay, so help me answer the question right. So how can it affect the body long term, or what will you experience during?
It's not, well, there's a follow-up question that says, what does a miscarriage look like? So maybe sort of what is that process like? And then are there long-term effects that might come with that?
Okay, so in most cases, the process, different kinds of miscarriage, I won't go into details, but a spontaneous miscarriage typically is just a lot of cramping, pain, kind of like your worst menstrual cramp that you've ever had, and typically very heavy bleeding, heavier than your normal period. And that may last for typically a couple of days. And then long-term, a spontaneous miscarriage, having one miscarriage, even two miscarriages long-term, it does not harm your body to have spontaneous miscarriage. But if you have 2 and 3 kind of miscarriages, especially kind of back-to-back miscarriages, that may mean there may be some type of issues, type of physical issue with the uterus or cervix that's causing you to miscarriage. Or it can mean that there's an issue with a chromosomal problem with the pregnancy, or a chromosomal problem with that woman. So normally if you have somebody who has 1 or 2 miscarriages, very, very common, doesn't mean anything's wrong with the patient. It may just be that pregnancy was likely chromosomally abnormal, so it didn't continue. But if you got 2 and 3 miscarriages, then we can typically have you get different testing, blood testing done, ultrasound done to see is there a reason why you're having kind of back-to-back current miscarriages.
But it doesn't harm your body to have a miscarriage. You can still go on to conceive after a miscarriage.
And then there's another question that says, how does not having a cycle affect the body? And I think the question is just that naturally not having a cycle, so not necessarily like birth control induced, but I guess naturally if you maybe don't have a regular cycle. But you could also maybe touch on how birth control that prevent periods for extended lengths of time, if there is some long-term effect that we know about, and what that might be as well.
So there are a few different reasons why you cannot have, obviously, talk about non-pregnancy here. So rule out pregnancy. And if you're not having a period for a couple of months, I think there's some type of hormonal problem. Typically women who are very much underweight or even very overweight can have issues where they miss periods or skip periods. Thyroid disease, whether too low or too much thyroid hormone can make you miss periods. So normally it's a hormonal issue. Now we're talking about somebody who's never ever had a period ever. That's a whole different situation I won't get into. But if you've had a period before and you start missing them or skipping them and you're not pregnant, then it can be a hormonal problem that needs to be checked on, or it could be an issue of weight, because the more weight you carry, or very, very underweight, you don't have enough, your hormonal environment is not normal to be able to have a regular period. And if you're not having periods, you're not ovulating, and so your ability to get pregnant in that time frame is going to be low to not zero, but low. And there are different birth controls. Most birth control pills will give you a regular monthly period. There are birth controls that stop your period, things like intrauterine devices or IUDs or Nexplanon, things like the one in your arm. Those things can make your periods go away for a period of months to years sometimes. And when you're on a hormone that's working to stop your period, it's not a harm to your system, because the hormone is keeping your body in a state where you're not able to get pregnant and not ovulating and therefore not having a period. So it doesn't harm you. And actually, in some cases, especially with birth control pills, they actually can decrease your risk of certain ovarian cancers over time. So they can be helpful for multiple reasons.
Does anybody have any last questions? In class, I'm going to be the teacher now. I always have my students give final thoughts at the end of classes where we have a discussion. So each of you can just give us just a final, I don't know, message, takeaway, your favorite quote, whatever it is that you would like to, as your final thoughts, sort of leave with us. Dr. Maury, do you want to start? No pressure, make it good, no pressure.
After I told you that I was an introvert. My final thought, I guess, thank you guys for inviting me. This was really nice. I learned a lot. Coming from an assistant professor, I always try to with my students, and I would speak to my students, same thing. I'll tell you, I tell my students, stay curious. Okay? Don't let your outside limitations limit you on your inside. You know what I'm saying? Just because you're a female or you're black and you have an accent, don't let that stop you from, being curious and achieving what you're supposed to achieve. Okay? That's my final thought to everybody.
Well, also, I enjoyed the invitation. I had a good time today. I would just say, speaking from my own background, what's helped me, I would just say, in everything you do, try to put God first. That's, to me, the most important thing, and that will lead you to what you need to do and lead you to the right path.
All right, thanks so much for having me. I enjoyed getting the time to get away from the office. But I do want to encourage you. Just study hard. Stay focused. That's the thing that I need to do, okay? I do not feel that we have yet arrived, and you still probably need to do twice as much, unfortunately. When you study twice as much. Whatever you're gonna do, just study. Whatever work you're gonna do, just do more. Because we have not yet arrived where we can get away with certain things, when others can get away with it. I just don't feel that we're there yet. So don't throw in the towel. Stick with it. Take it all the way through. and you're gonna do just fine. Okay?
You know, I would like to thank y'all for allowing me to come here. It was a great experience to actually give back to the younger folks here. And, you know, I'd like to say that we've come a long way, but we haven't gotten to where we need to be. You know, we have come from a history of being able to overcome so much, from slavery, Jim Crow. We've done things that other people would never even dream of doing, and we can do so much more. So keep that in mind. Whatever your pursuits are, just give it your best, and you can do whatever you want, and you can achieve it.
Well, thank you all so much for being here. Thank you all so much for coming. If you guys have any questions or any thoughts, you can shoot me an email. I'd be happy to get in touch with any of our panelists. So I might be bugging you guys again. But keep your eyes out for upcoming events and let me know what you guys want to do.